Um, Good afternoon, everyone. It is about 2:30 in Nairobi City. I do not know where you are joining us from, but I want to welcome you to this webinar that we are hosting today here in Nairobi. We are Medso Sans Frontiers, or otherwise known as MSF, or the English name we go by the name Doctors Without Borders. And today we just want to have a session in the next hour or so, just to speak about how we respond during medical emergencies. A lot of things have been going on around the world, around the places where we live. We all witness during different times different emergencies of different magnitude and different nature. And as MSF, we usually respond in different contexts, in different countries, whether big or small. And today we just want to have an understanding of what exactly it means, what we qualify as an emergency, how we respond, and what normally happens during such emergencies. My name is John Riaga, and I work for MSF here in Kenya, and I will be moderating this discussion this afternoon. With me, I have a panel of three who are going to help us understand what we are speaking about when we speak about medical emergencies and what happens during those emergencies and how we respond. So I have a team that is here with me that is going to help us delve into this topic, and so that we can understand it better. And I will allow each one of them to introduce themselves, just tell us who they are and what they do, and what their introduction would cover, so that even before we begin, we already have an understanding of who is here. But before we get to that, I would just like to remind each one of us of a few etiquette, some of the things that already we know. Just a reminder that remember to mute yourself unless you are speaking. Just let us know if you have any question that you want to ask in the course of this discussion. Feel free to use the chat button. We have a team that is here that is helping us, the technical bit, and we can assure you that we are well on track to be able to cover everything. So please remember to mute yourself. And if you have any question that you want to ask, please use the chat button, and we will be able to look at your question and see how, if it is possible, and how really to give you the best answer. So without taking much time, I would want to allow my panelists to introduce themselves. I will start with the lady in the panel, who will go first. As they say, ladies first. And then Kelly will go next, and then Kennedy. And then once we are done with the introductions, I will guide on the question and just how this discussion is going to take place as we move on. Thank you very much, and welcome for joining us this afternoon. Nancy?
Thank you, John. I go by Nancy Nyambura as my name. I am working as a psychologist, a staff psychologist with MSF. And I've been with MSF for almost 10 years now. I've worked in several countries, including Cameroon, South Sudan, Nigeria, Bangladesh, and Ethiopia, some of the countries that I've worked in. Thank you very much.
Thank you, Nancy. What do you do at MSF? Maybe you could just speak about that as well.
Right. I'm a psychologist by training, clinical psychologist. What I do in MSF, I work in a unit called Staff Health Unit. And this is the unit that is dedicated to taking care of our staff all over where we are working in terms of their mental health. So we work in preventative, curative, and supportive interventions towards our staff.
Thank you so much, Nancy. So we have a clinical psychologist in the house. We will come back to you later, Nancy, just to delve into what that means in terms of your experience and your role. Kelly.
Yeah, good morning, good afternoon, and good evening, everyone, depending on where you have connected in from. I'm Kelly Habala, Deputy Medical Coordinator for MSF in Kenya. Myself, I have 16 years working experience with MSF, here mainly in Kenya, but also supported South Sudan and lately Sudan. Yes, and having worked in both regular and emergency projects. Thank you.
Thank you very much, Kelly. That's a good profile. I know we will come back to you to so that we can understand the Kenyan context and what it means in terms of what you are speaking about. I now bring to you Kennedy. Please introduce yourself.
Hi, everyone. So my name is Kennedy Olela. I've worked in MSF for the last 20 years. This is my 21st year in MSF. I've worked in different countries in the medical department and currently in the operations. So I worked in Malawi, Ethiopia, Nigeria, South Sudan, Sudan. So Yemen as well. These are the countries that I've worked in. So currently I'm Deputy Director of Operations for Okuba, Cell 5. Our portfolio countries are South Sudan, Nigeria, and Somalia at the moment. Thank you.
Thank you very much, Ken. Thank you, Nancy and Kelly as well. From that introduction, I get the feeling that we are speaking about a global type of experience. I've had countries from all over the globe, and it's really exciting to understand that the three of you collectively have what I would call a global experience, and we will tap into that experience shortly. Maybe we begin with Kennedy. When we speak about an emergency in the MSF, language or context, what exactly are we speaking about here?
Yeah, so when we speak about emergencies, it's a situation where there is rupture of equilibrium in terms of within the populations. We are talking about vulnerability. We are talking about medical humanitarian needs increasing to the extent that the population survival is threatened. There is high mortality. There is high morbidity. So generally in MSF, we're talking about man-made and natural disasters, outbreaks as well. So this is what we talk about in MSF. So ensuring that, saving lives, ensuring that the disease reduction of mortality, morbidity, ensuring that the population receive medical and humanitarian services.
Kennedy, when you have said a word there that I just want you probably to break down slightly. When you say rupture of equilibrium, just break it down. Are you speaking about physics or chemistry, or we are still in response to emergencies?
We are speaking about in response to emergency. I think, in MSF, there are patients and populations behind what MSF does. So this is a situation where, things are broken down, the population are displaced, diseases, people have been infected, affected, their populations dying. So the normal human, situation is interfered with, so not normal living. We have population, people dying, disease outbreak. So it's a situation where it's not normal. It's abnormal situations where populations have been affected in terms of health, in terms of basic human needs. So this is what we are talking about.
Yeah, thank you. Thank you for breaking that down for us. And now that we have understood what an emergency is, and for many people, anything that disturbs, what you call anything that ruptures your equilibrium could be urgent. It may be small. It may be small as per MSF states. How you put it, but for me, it could be big. So quickly, the urgency, how do you then decide that this is urgent? I know you've mentioned, but if you could slightly dig a little deeper, how you then decide that this is urgent and we need to move in, and how fast do we move in? And, so how quickly usually do we respond? Maybe as you respond to this, you can probably give us an outlook, how it looks like the first few hours of what this disruption looks like, Kennedy.
Yeah, so I think one of the objectives is reducing the mortality and the suffering of the population. Then early response means saving more lives, and bringing, the emergency threshold into the acceptable levels. Then we need to have there is, reactivity to respond to this, early detection of diseases, early confirmation, then prompt implementation of that response. So when we have a situation, for example, where there is conflict, for example, we look at the population that is suffering there. What is the magnitude of that population, the magnitude of that case, and what is the capacity of the government, for example, and the organizations that are in those countries that can respond. So that will define how fast we need to move. And as MSF, we need to remember that it's a medical emergency humanitarian organization. So we are responding to emergencies based on the magnitude of those emergencies. So the more population is affected, that will push us to respond fast so that we can save as many lives as possible. Whatever we do as MSF, there is life of population behind it. So this is our focus, ensuring that if it is an outbreak, then we have to bring that outbreak to a halt. We have to save the population, the lives of the people that are there. We have to ensure that the normal basic human needs are covered. And this is how we need to respond based on that. How many people are dying? What is the population age group? Who is affected? Which is this area? The capacity of the government, as I mentioned, and what we can do as MSF, and how do we involve the rest of other organizations and the governments are there. But there's also one aspect that there are countries where outbreaks come, but we are not there.
Mm-hmm.
So this makes it different. There are countries where we're already working there, so that will facilitate our response because the teams are already there. They understand the context. But in new context, it comes with a lot of challenges. There is engagement with the authorities, the assessments that needs to be done, how many people we need to bring in, how do we declare these outbreaks, because we are facing a lot of challenges in terms of declaring outbreaks because of the government policies in those countries. These are how fast we need to look at all this. How many lives can we save in that situation?
Thank you, Kennedy. I want to bring in Kelly to just give us a picture of what the Kenyan situation looks like. Having worked around for 16 years, I mean, we haven't seen the emergencies of the magnitude of like we see in other countries, earthquakes, where there is mass casualty. And I would want you to just speak to that in terms of the response that we have had in Kenya. But before we come to Kennedy, you've mentioned something about context where or countries where something happens, but there is no presence of MSF. Maybe just in a minute, how does it work when something has happened in a country where there is no history of MSF? Do you tell the government that we would like to come in and help because of this? Or do governments come to MSF to say, hey, we have this going on, would you come and help us? How does it work?
The first thing is ensuring that we engage the government of that country. Because for you to be able to work in a certain country, you have to get permission to do that. So the first thing is to have a clear engagement as we plan for quick, rapid assessments that we do normally. There is that level of engagement at the government level that as MSF, we start with that. Because whenever there is an emergency, countries are calling for international organizations, international community to support them to respond. So that is the opportunity that we always have as MSF, that once that is done or before that, we engage with the governments to ensure that we can be able to work there. Because one other aspect is the safety of the teams that are going inside. you can only do a response if your teams are also safe. So first of all, engagement with the parties that are involved, if it is a conflict, for example, if it is an outbreak, the Ministry of Health of that country has to be involved. So very quick response means you have to do these things as fast as possible and ensure that the government of that country is aware of MSF coming in to support. And normally it's quite fast whenever there is an emergency. That level of engagement are done at the first hand. Then the response, rather will just come very fast because the countries, maybe they don't have that capacity to respond.
Thank you, Kennedy. Kelly, let me come to you, and then, of course, we will bring in Nancy to give us a psychological aspect to the discussion that we are having here this afternoon. Kelly, I know, like we all agree that we've not had, very big, so to speak, emergencies in Kenya, but MSF has been in Kenya for a long time, responding to different and providing different interventions. Would you please just paint for us a picture of what the situation in Kenya looks like?
Yeah, for sure. And first, I would wish just to explain that, when we say a big or small, emergency situation, I think is relative. Because in medical terms, even if we lost one patient, I think or one person or one life, that is serious enough. So anyway, in Kenya, of course, in collaboration with the government, usually we have an emergency response plan. Yeah, as you may know, in regions that we work, we have already some collaborative arrangement with specific regions. And of course, before doing these agreements, usually we are doing an assessment just of the health profile of each country before developing this strategy. And one of it, like for sure in Kenya, when you look at the health profile, it already tells you that there is some level of vulnerability for some either possible outbreaks or even natural or man-made disasters. So it's upon this strategy that now we build our emergency intervention response. So for the last few years, I would say 3 years backwards, we've had quite a number of emergency situations in Kenya. If I start by region, for example, in Homa Bay, we've had an outbreak of cholera. We've had displacement of internally displaced people, and MSF has responded to this emergency. In Nairobi, where I'm mainly based, we've also had a cholera outbreak, which MSF has participated, of course, together with other partners to respond to this. We've had cases of mass casualty, which is resulting from, for example, the latest street or urban protests that we've seen, where MSF has put up an emergency ambulance system. And over time, we also have, an emergency unit at Juja Road on Lavender House, where we are managing, road traffic accident survivors. In northern Kenya, we've had response for cholera, measles, Rift Valley fever in Garissa, in Wajir, in Mandera. We've also had some response on malnutrition as an effect of prolonged drought that has been there 3 years ago. We've done this in Marsabit, also in Turkana, and also in Garissa. And currently, MSF is continuing to engage in 2 big responses that are ongoing, one of it being measles outbreak now in Dadaab. And also we have, IDPs due to, these are internally displaced population due to flooding in Tana River. and of course, the very latest one where we've had some influx of refugees from all the way from Kakuma to in Kiambu. Yeah.
Thank you, Kelly. Maybe one would ask, maybe one question would be, is there, at what point do you declare that an emergency, has ended, and now you fold, or as MSF you fold and now have to leave and probably move to another place? Is it when, or let me not say the words, but if you could give us your own words on what point do you now say that this is now ended, we are now moving maybe to another location?
Yeah. Just as Ken had explained before regarding to why we get into an intervention, part of these parameters, we also use them as indicators for exit. Yeah, for example, after we are very keen initially to support the acute humanitarian and medical need acutely. So in this phase, after we roll out the intervention, we are monitoring over time based on the duration of how we foresaw this intervention to run. So we look at the indicators in terms of magnitude. If the magnitude of those populations at risk is reducing over time, this could be a reason to consider an exit. We look at mortality, for example. If we are able to control mortality, this could be also a consideration. And then, of course, we have other compounding factors like, just the coping mechanism of the community, because sometimes we get into emergency situation and they end up being chronic, but the community is able to have some coping mechanism level that now they are out of an emergency phase. We also look at the local capacity. In this case, most of the emergencies in Kenya have happened are more related to outbreak. So we've been working very closely with the Ministry of Health and various county government departments of health. And yes, sometimes we are monitoring their local capacity because some of them during the initial phase, they may not be very ready, to do an intervention, but over time when the intervention is going on, they have been planning to do some level of intervention. So sometimes you realize that during the continuation phase of an intervention, MOH has come up with a capacity to manage. And also we look at the capacity of other external partners who sometimes they are also planning to have this intervention, but maybe mobilization of resources may have been delayed during the initial phases, but later on, usually they are able to increase their capacity. And yes, MSF considers to hand over usually or pull out completely. Yeah.
Thank you very much, Kelly. Ladies and gentlemen, if you are just joining us, this is Medsource Sans Frontiers, or MSF, or also known as Doctors Without Borders. And this afternoon, we are just having a discussion on what happens around medical emergencies, because we are a medical humanitarian organization and we respond during emergencies in several parts of the world. And so this afternoon, we are just looking at Sorry. Are we all back? We had a technical issue where I am, and I think we went off. My apologies for that. Before we went away, let's just wait for Nancy to come back. As soon as she comes back. But as we wait for Nancy, I was going to ask Kelly. Normally, how is the process? I know Kennedy mentioned, and you also alluded to it earlier on, because I know that you probably send in people to that place. They go and survey. They look at the area. Then probably they bring back a report, and then you say, now we are going in. Would you maybe, as we wait for Nancy, just take us through, step by step what happens until you find yourself as MSF in that intervention until you declare it done?
Yeah. So usually as MSF engages in every country, there is always a prior, engagement in regard to the history of some emergency situations, or what we call hazards in a particular country. Yeah? So usually, for example, in Kenya, when we are engaging, by that time, we went back, 5 or so years, just to look at what is the history of emergency events in Kenya. And then there is a way, of course, is a multidisciplinary team engagement to see what are the possible risks that this particular emergency may occur. So based on this, usually we are positioning ourselves already through an emergency response strategy, where we already in a country we have some pre-positioned, for example, medical stock for particular emergency situations. In this case, I would give an example like cholera in Kenya. Now we have some already medical supplies that should be able to intervene for cholera outbreak of a particular magnitude in case it occurred even now, tomorrow, or in the near future. So usually there is this kind of preparation, and this preparation, of course, is based on various surveys and analysis of data and trends of this particular event from both the government, which in this case, for example, the Ministry of Health, and also internally, we are doing some level of surveillance through the projects that we are running in this country. So usually with this now put up surveillance system, we receive alerts, from all over the country. Yeah? Possibly you have 1 or 2 cases of measles in, for example, Lamu. You have 2, 3, cases of whether it's dengue or whatever in which location. After we agree that it's developing into an emergency situation, we send a team to do what we call an explore or a rapid assessment. Usually it takes a very short time, in about 10 days or less. We have a team of trained staff who try to run there. One thing, just to confirm that we have these specific cases, and they actually meet case definition. And if based on the particular case, in this case, a morbidity that needed some lab confirmation, we ensure that it's confirmed that it's a real case. During this exercise of confirming, we also now investigate other things. What is the coping mechanism of this particular community? What is the locally available, resources or plan that exists to do this response? And could there be any other external partners who could be willing to intervene in this situation? So in addition to this, we are also paying close attention to the number of mortalities, as it was explained before, that how many lives have been lost, and what is the threat of a bigger population being affected. And then from all this analysis, we come out to pick the gap. Now, after picking out the gap, this is what we now call the needs, the humanitarian and medical needs. But now we need to design kind of an intervention to really manage the identified needs. Yeah.
Thank you. That is comprehensive. Nancy, welcome back. For a moment, we thought you had gone. So Nancy,
apologies, technical.
No, it's a technical problem. It affected almost a good number of us. I want to bring you into this discussion. You're a clinical psychologist, and so what does it mean? Why is it even important for an organization like MSF to have a clinical psychologist? Is it just by design, or is there a necessity? So as you answer this, just give us a picture of what your role entails in terms of emergencies and this discussion we are having this afternoon.
Right. So according to World Health Organization, there is no health without mental health. So mental health is a component of a healthy person. So I might not have disease in the body, but if my mind is not at rest or it's experienced some disturbance, I cannot claim to be healthy. So in that sense, in MSF, we are integrating mental health as a very crucial component of our response in emergencies. So it's part of what we do when we respond to emergencies. What we do is we have a very integrated approach. And what does this mean? It means that we are looking at both the physical and mental health. And with the mental health, we have psychologists, we have counselors, and we have psychiatrists on board. Psychiatrists are the medical doctor who are specialized in taking care of our mental health. So they give us medication to stabilize us and to make our symptoms much lesser. So this is how we approach mental health response in MSF. Again, also, it's very culturally informed. What it means that we are culturally sensitive, even when you're doing our interventions. Like Kelly was saying, when you're doing our needs assessment, you're also looking at the resources that are available. So we also look at that, what is available, what do people in this context do to take care of their mental health. So we do not come impose, and we do not come and disregard what people do. Again, it's very trauma-informed. What this means is that we endeavor on minimizing or mitigating the impact of trauma to the population that you're working with or we are responding to. And also our interventions are geared towards avoiding re-traumatization. What this means that we avoid, whatever we are doing, we avoid causing more trauma or more psychological harm to these people that have been affected by the disasters or the emergencies. The other thing is we also look at different populations. Different populations have different needs, and therefore we have different interventions, or our approach is going to be different. For example, if the population that have been affected by the disaster or the situation are children, our approach is going to be very different compared to if it was the elderly, or maybe a group of women have been affected. So we're also looking at who is the target population. Therefore, we can be able to come up with an effective approach in responding to their mental health needs. Being an emergency, one of the things we do when you're doing a needs response, or the first response, is something we call psychological first aid. And essentially, this is mapping what are the immediate needs. For example, if someone has not eaten, for 3 or 5 weeks, I'm not going to sit with that person to ask them, what are your feelings or what are your thoughts? I'm able to identify the need is first a meal, a healthy meal. So we do this psychological first aid intervention, and then we're also able to do assessment and resource mapping, what is available, what are the needs, and this is where we then come up with intervention plan. And now I'm talking about mental health intervention plan. We are not working separately, we are working hand in hand with the medics, and therefore it is being integrated in what you're doing, we are doing in responding to this population. We train counselors as well. Counselors are people from, the population or the area. We train them with skills and knowledge on taking care of mental health. And we just don't abandon. We also do support as ethically required. We offer something called clinical supervision to these counselors as they do the intervention. This is offered by trained personnel, mainly clinical psychologists or psychiatrists who are offering this kind of support. Of course, this also comes with collaborative efforts. When you're responding, we're also doing awareness, because yes, there's an emergency. Does the population know what you're doing as MSF? We've gone to intervene. So we do a lot of awareness in the community, and mental health awareness is very, very key when you're talking about recovery after disaster or after an emergency situation. So we train community health workers in creating awareness in the community. And the beauty of it is that they are culturally aware of what is appropriate and what is inappropriate to say. So this is one of other way we intervene. So the more awareness there is about mental health, illnesses and mental health interventions, the lesser the stigma. And stigma can be two ways. It can be self-stigma, I stigmatize myself and I'm not going to look for help, or it can be stigma from without, from people around. So we've seen this as a very effective way of making mental health intervention palatable and more acceptable to people, to communities. Again, also, if there's an emergency, safety is very, very compromised in this sense. Therefore, we create safe spaces when you're doing mental health intervention. What I mean is we create counseling rooms that are conducive and meet ethical standards, privacy and all that. And for example, if it's a group of children, or children are also part of the people affected, we are also doing play therapy with the children. We create an environment where children can feel safe and can be able to process what has happened to them. They can be able to express, their emotions and thoughts in regards to the impact of the situation. Back to you, John.
Thank you very much, Nancy. I have heard you, outline in terms of community, but I'm thinking about Kennedy and Kelly here. Under your unit, or is it that they are okay? Are they hard enough to survive through these things you're speaking about? Something about your own people or MSF people who are out there during these emergencies. And then we will come. I can see there are a few questions that have already come in. Maybe you respond to that. And then probably later on, both Kennedy and Kelly can give us, if they have something to say, if they have benefited from, from this type of, psychology in terms of the work that they do. So Nancy, about your own stuff.
Right. Very relevant question. One of the hazards that comes with humanitarian aid work is exposure to human suffering. So we are not removed from this human suffering. We witness by hearing and seeing the impact, and therefore we are exposed to things like vicarious or secondary traumatization. We are exposed to post-traumatic stress disorders and traumatic stress. And MSF is a responsible employer, and that's why we have a staff health unit. When you come to sending Kennedy, before Kennedy is sent to go and respond to an emergency, He will have a session, and not just Kennedy, any staff, they have a session which prepare them psychologically, and we talk through, we take them through, you know, what are the hazards they are likely to encounter. We look at what strategies they have to take care of their mental health, and we reinforce that. We also accompany them. When we send them, we don't abandon them where we send them. We do regular check-ins, and also proactively they can reach out to us. We do trainings which are relevant to them. And when they come back home, we do something we call return talk, or psychological return talk. And this is to reflect on their mission, to reflect during the time they were responding to this emergency, how did it change them? How did it change their worldview? How did it change how they take care of themselves? So we are helping them to reflect the impact of that mission, and also to come back home, because they're coming back home, but they have witnessed quite a lot. So how do they reintegrate back with their families, to their communities? We also have staffs who are working, and they're from these places where it has been impacted. We do have resources as well. We care for them. We don't, neglect them or say, they've seen so many adverse situations, they are able to cope. We don't assume that. We also offer this kind of support. So every staff that is working with MSF, they have access to this resource, and it's ongoing. It's not a one-off. So yes, their mental health is very, very important. We cannot take care of others if we don't take care of ourselves first.
Thank you. Another question for you, Nancy, would be, even as a psychologist, when you sit down with, say, Kennedy, when it comes from such interventions, who takes care of you? You will answer that later on. I can see there are questions from the chat. There's a question from Sheila. Does MSF provide food and basic needs in IDP camps? I will throw this to Kelly. I know you mentioned there's a part 2 of that question is which emergency responses have you done in Kenya? I know you mentioned this. Probably you can take that together. I know you mentioned Garissa, and probably in other countries we have had IDP camps. So does MSF provide food and basic need? What are these basic needs? If yes, what are they that MSF provides? And then what are some of the emergencies that MSF has responded to in Kenya? Kelly.
Yeah, thank you for this question. Yeah, to answer you, I would say yes, but depending on the assessment. Because so far we have been involved in quite a number of, for example, malnutrition intervention. In malnutrition intervention, usually after the assessment, we also look at all those things we've talked about. What are the other actors doing in the field? What capacity do they have, and all that? So usually we try to focus on acute, the emergency need. So for example, for malnutrition intervention, we may see that for the very sick who are severely malnourished, are likely to die or to end up with complications or other comorbidity. So based on existing assessment findings, we then say, yes, MSF, let's only take care of the very sick ones. In this case, we call them acute severely malnourished children, where in this case, we are going to offer what we call therapeutic feeding, where we give some nutritional treatment plus nutritional supplement for them. And sometimes we have given a food package to the family, because there are some interventions we've gone and we realize possibly the child is also getting very malnourished because of other socioeconomic issues. So you have to cushion other family members so that they don't share this nutritional therapy. However, there are some contexts where we've gone and we realize we have other players who are doing very good job, and they very experienced and they have a scope, for example, of food distribution. We are then partnering with them so that then we kind of specialize in a particular, area of intervention, and then we collaborate for them to do like food distribution. We've done this before with WFP, where we've ended up, because as MSF, it was very heavy to do, what we call case management. For example, we had an emergency intervention in Ileret in Marsabit, where MSF ended up having what we call an ITFC, Inpatient Therapeutic Feeding Center. So we take care of the very severely malnourished children, but upon discharge, they need a food package to continue for the whole family. Then we would link up with the WFP to do this food distribution. Just also to share that for sure, at times after assessment, we realize the needs are more than what the local mechanism, which could be local governments and even some partners and even the community to offer an intervention. Usually we are also picking it as an advocacy point, and then we kind of lobby. There are situations where in some emergencies we are not able to do everything, and we have linked this need with the rightful partner, whether it's national or internationally, so that then the beneficiaries are able to gain from the needed intervention. Yeah.
Kelly, maybe one or two recent emergency response that we've done in Kenya. I know you mentioned earlier, but for the sake of Sheila, I think.
Yeah. Okay. To recent one, I would say, of course, one of these street protests that we've seen in Nairobi, where MSF has deployed ambulances and put up emergency units in Mathare or on Juja, and also supported Kenyatta for the triage and managing these surgical cases. We have an ongoing flood intervention in Tana River. As we may know, during March, April, May, we had lots of rains that caused the displacement of population in Tana River, and this intervention is ongoing. We've also had one recent one in Baringo due to ongoing conflict. Some families have been displaced there. And then on top of it, also it came the flood, so it displaced more people in the same county in Baringo. MSF has done an intervention there.
Thank you.
Thank you.
Kennedy, if you could respond to there's somebody is asking if MSF charges for medical care services, if you could know at your level. And then there's another question that says, in what ways can the public or other organizations support MSF's emergency response efforts? I know Kelly has mentioned how we collaborate with other organizations, but if you could add maybe something on that, other organizations, how they support, and even the public, how the public can support the work that MSF does. And the second question, if people pay for the services that MSF offers.
Yeah, just maybe to add something on Kelly's. In acute cases, MSF, you hear me?
Yes.
Yeah, in acute cases, MSF provide these energy biscuits, which are distributed to the population as the advocacy goes on with other organizations who provide food. So I think one other aspect was distribution of non-food items that MSF does in emergencies as well. This is part of the package that we do as we advocate for other organizations to come in. Coming to your question, MSF provide free medical care to in all our interventions. Of course, there are donors behind that make this happen. So in terms of payment, MSF do not charge any services that they provide to the population. The other question?
Members of the public?
Yeah. Well, I think as MSF, we have laid out strategies on how we respond to the needs of the population where we work. So the population can contribute in terms of donations to MSF so that we can be able to run our activities and services to the population affected in different countries. So public, I think you've seen what has been happening in different countries. All the money that MSF spends is donated by individual people that offer their services to. So the general population, we urge, the population, whoever feel touched, that they can support MSF in terms of their responses. There is a fundraising department of MSF, which I believe the team here will share their contacts so that they can reach out to the fundraising team to be able to donate whatever amount they can to be able to support our activities.
Thank you very much. Before I go to, there's a comment by Bernard that says MSF is a game changer. I have seen the activities in Garissa, especially during measles outbreak interventions. Kudos. That is from Bernard. Somebody else is asking if MSF offers attachment, and I think our technical team will direct you to our socials, where we usually post some of these things, and you can follow from that point. Nancy, who takes care of you when you take care of the team psychologically?
Great. Good question. Again, MSF is a responsible employer, and as such, there's a setup to have technical supervision from more qualified, more experienced senior staff, and also there's a resource to get professional support. What this means is I can get what we call in psychology clinical supervision externally as well. MSF provide for this. And also every staff has access through the insurance to have mental health care. And therefore, if I need this and I've utilized it in the past, I can go and speak to a psychologist and to take care of my mental health. Because our work is very, very fulfilling, but also it comes with a very unique hazards, occupational hazards, like I described earlier on, the stress, the exposure to trauma and human suffering. So there are resources to make sure that I'm well, and therefore I can take care of our staff.
Okay, thank you very much. Kennedy and Kelly, I want to bring this to you, this whole issue of clinical, psychology. Having been out in the field for so many years, you have seen different interventions of different magnitude. You have witnessed a lot of even this suffering that we are speaking about as you respond. What would you say briefly in terms of the psychological support that you receive from the staff health unit? We start with Kennedy and then Kelly.
Yeah, thank you. Just as Nancy mentioned, before any deployment to any response, there is a process that we normally go through, having the psychosocial support, preparing you psychologically where you are going to. Because sometimes, as you know, there are very, very tough areas that you need to go. So I think the presence of the psychosocial needs in MSF is very key, because it helps people to be able to have resilience in terms of working in those difficult contexts. So it's something that is there, and it's been helping. Like Nancy mentioned, before any deployment, you have to be taken through those briefings, what is expected, what you may be encountered with, so that you go there prepared that this is the situation that I would be facing. And that will also help you to prepare yourself in terms of how you want to provide services to the population. So it's something very key in MSF. And we thank the psychosocial team with Nancy has been very, very key in this. She's really worked in different contexts with us. in all those tough missions where we've been. So I think this has been, like what we can say, a game changer in terms of how the staffs are prepared to respond to the needs of the population.
Thank you, Kennedy. Kelly, anything to add?
Yeah, no, for me, it's just to add that actually mental health is one of the key priorities for MSF. And during emergency intervention, just to say that internally, we also have a keen eye on what we call, key priorities when you are doing an assessment. So as you assess the needs of the beneficiaries, mental health is one of the key components that has to be assessed so that we, understand the needs properly and then design an intervention needed. Equally, for the staff, staff health actually is one of the key elements that we always consider in any setting that we go. In fact, we always do an assessment of, staff health. What is the capacity of, this region where you are going to put staff for the intervention? If this region has a capacity to respond to the healthcare needs of your staff. And one of the things is mental health. Then from here, of course, there's a way we design on whether what Nancy has explained, you are going to do telemedicine, or you need a psychologist in the field to be with the team, or even the way we design our duty rota for emergencies. We've seen even in other countries, things like Ebola, there's a very intensive emergency response. You need to change teams quickly, of course, other than preventing the risk of infection, but just to avoid burnout. Usually we are working out this system. And then we have special debrief sessions after a period of time for each of the staff who, one, are involved in areas we think could cause mental health stress, but also it's open to any other staff who feels needs some mental health care. Yeah.
Thank you very much. Thank you. Nancy, final question. Does everyone have a breaking point mentally, or from experience? We have people who, are hard and they just go on and on regardless of what's going on in their lives.
Okay, I'll put it in an analogy. You cannot cross a river barefoot and not get wet. Okay, so what does this mean? It's not a matter of if, it's a matter of when. So what we work on is helping people to know their capacity and helping people to know their limits, and destigmatizing, someone coming to say, I've reached my limit, they are supported. So they're not perceived as if they are weak or they're not capable, but actually it's a sign of strength for you to be able to know, I've reached my limit, and therefore I need to do whatever I need to do to replenish and to recover my resilience so that I can be able to last long. And finally, to say that humanitarian aid work is like a marathon. Kenya is a marathon running country. A marathon, you don't exert yourself in the first 10 kilometers. You will not be able to complete the 40 kilometers. Therefore, we are the 42. It's 42, John, or 40. Therefore, you are empowered to be able to manage the terrain. Sometimes you have to climb a hill, emergency, and therefore you need to exert yourself. And sometimes you have to go down a valley and you don't need to put a lot of energy to be able to go downhill. So yes, everyone has a breaking point. And the good news is you don't have to break. You don't have to reach there. You can know before you reach there, and you can mitigate breaking.
Thank you very much. I have one final question that has just popped up. I will leave it open for any of you to give an answer in maybe 10 seconds because we have to close. In a war zone area, what safety measures do we put in place for the staff? Any one of you, a quick answer in a war zone area? What happens?
I think the first thing is engagement and networking with the with the actors on the ground. This is key, because if the place is not safe, then you will not be able to do an intervention. So engagement and advocacy is key. Knowing the actors mapping who is responsible for what, who controls where, access and all these things. So the very important aspect of it is the engagement with the actors on the ground to ensure that safety, because number one thing is the safety of the team before any intervention is set. Thank you.
Thank you very much. And on that engagement note, we have come to the end of our webinar this afternoon. We have been speaking about the MSF response during medical emergencies. And we were privileged to hear from 3 experts, Nancy Nyambura, Kennedy Olela, and Kelly Kabala, who have really done a great job in just painting for us a picture of what a medical emergency is, what actually happens while we are in there, and the very important bit of psychological support. Just to finish, I just want to let you know that we can continue this discussion. We can continue engaging. If you really want to probably know or keep engaging with us, you can visit our social channels, you can visit our website, and we also have an opportunity that you can sign in and be able to receive our monthly newsletter where we give an update of the things that we do. We also give an update on some of the things that you want to do in terms of supporting. You have just heard that MSF is supported by private donors who give out their money and support so that we are able to do some of the work that we do. So feel free to engage us even off this webinar on our socials, on our website. Reach out to us and speak to us. Thank you very much for spending about an hour or so with us as we delve into this topic. My name is John Riaga. Thank you very much, and see you probably soon in another engagement. Thank you.
Thank you, John.
Thank you. Bye.
Well done.